Well, kia ora and good afternoon, everyone. Thank you for joining this Spotlight series on COVID-19 and public health. Today we'll be focusing on two topics with two different speakers. Dr. Deborah Harris will speak on contact tracing and the view from nurses on the ground, and then Dr. Fiona Imlach will speak about consumers' experiences of primary health care during level 3 and 4 lockdown. For those of you who are joining for the first time, I'm Professor Gregor, Dean of the Wellington Faculty of Health at Victoria University of Wellington, and I'll be moderating today's session. We hope for a lively discussion with our panelists, and we'll be using a Q&A function if you'd like to submit a question sometime during the panel presentations. We'll aim to answer as many questions as possible, and the webinar will run for around 1 hour. Now, if you want to ask questions, it works like this. If you move your cursor to the bottom of the screen, you'll see a image with marked Q&A. If you click on that, it brings up the Q&A box, and you can then type your question into the box and it becomes visible to everybody. People can then vote on it in the side area, and those questions with the most votes will come up to the top, and we'll take those questions first when it comes to question time. We're going to have the two presentations one after the other. Questions will come in, and then we'll do the questions for the panelists after both presenters have presented. And we'll keep any unanswered questions for our presenters to consider answering afterwards if they can. So let me introduce today's panelists. So the first presenter is Dr. Deborah Harris. Deborah is a neonatal nurse practitioner and clinically focused researcher. She's New Zealand's first nurse practitioner. Her doctoral work focused on the management and treatment of neonatal hypoglycemia, that's to say low blood sugar in babies. Her randomized control trial, the Sugar Babies study, showed that oral dextrose gel is an effective and safe treatment for neonatal hypoglycemia. Deborah has since published extensively about care and management of babies at risk of low blood sugar and the effects on their later development. Deborah's research has changed the treatment for babies and their families worldwide. Now, importantly for this webinar, Deborah was involved in setting up the Ministry of Health's contact tracing system and was posted there for 2 months during lockdown. So we're looking forward to hearing what Deborah has to say. She's going to talk about contact tracing and the nursing response to COVID-19. She'll cover off how contact tracing was established, what went well and what didn't go well, challenges with contact tracing then and now, and the nursing response to COVID-19. Welcome, Deborah. Thank you, and we look forward to hearing what you have to say.
Thank you, Gregor. Ata Mārie, everybody, and thank you for the opportunity to take part in this webinar regarding COVID-19 on the ground. As Gregor has said, I'm a nurse practitioner, and this was one of the reasons that I was asked on the 18th of March by the chief nurse within the Ministry of Health to give a hand, perhaps for 3 days, Deb, to help stand up the National Close Contact Service. There were 5 senior nurses asked to help with this, and my colleagues were all nurses from Capital Coast DHB. Today, I'm going to share a story with you about how we stood up the National Close Contact Tracing Service. As you're aware, rapid case detection and contact tracing, combined with basic healthcare measures, are over 90% effective against COVID-19 at a population level, making this much as effective as many vaccines. During the early part of our COVID-19 outbreak, each of the 12 public health units were undertaking contact tracing, which of course is part of their normal functions. However, largely this is for outbreaks such as listeria, like we saw in Tauranga late last week, things like tuberculosis. The point that I'm making here is that these outbreaks tend to be an awful lot smaller than what we have seen with COVID. Some of the public health units were completely overwhelmed by workload, And you will recall that we had large clusters initially in Southland and in Auckland. Therefore, the lack of capacity within the public health units was limiting our ability to conduct rapid contact tracing, and therefore there was a government decision made to have a national close contact service. So that's the reason it started. We joined a team within the Ministry of Health, which included public health physicians, protection officers, health managers, data analysts, software specialists, people that wrote software, policy writers, and managers who understood the ministry of, or the machinery, if you will, of government. We were also very fortunate to be joined by people from agriculture, those that had been involved in the national contact tracing for the Mycoplasma bovis outbreak, which was in 2019. And while there is a massive difference between cattle and humans, the experience of contact tracing cattle and talking to farmers gave us valuable insight and helped us to stand up the service promptly. On the afternoon of the 19th of March, we were making our first calls to those that had been in close contact with people who've been diagnosed with COVID-19. Our nursing team had many responsibilities. Perhaps the most important one was writing the scripts to inform the phone calls for the public. It was essential that our communication was current, clear, concise, and reflected the messages that were also being given in the daily updates from Dr. Ashley Bloomfield and our Prime Minister, Jacinda Ardern. The Ministry of Health website became our centre of truth, and we quickly established a method of discovering when that was updated. We developed a 3-call approach, and largely we based this on the Irish model. As the Irish people were a little bit ahead of us, we quickly reviewed international models for contact tracing and also the recommendations from the World Health Organization. I'm going to tell you a little bit about the calls now. Call 1 was to provide a member of the public with confirmation of the diagnosis of COVID-19 and where to get help and support. Call 2 was to investigate where a member of the public had been in situations, so places, or with people for greater than 15 minutes within the 2-metre distance. So this was sort of the sleuth phone call, if you will, and this phone call often took a long time. And call 3 was to confirm that a member of the public had been in close contact with somebody who was positive for COVID-19 and to inform that person that they needed to self-isolate for the required 14 days. Because we were the National Close Contact Service, we largely undertook call 3. But sometimes we were involved in all 3 calls, of course. Just to put call 3 into some context for you all, it would commonly go like this. I would call a member of the public, explain who I was and why I was calling, confirm that I was actually talking to the right person. I would then explain that they had been in contact with somebody who was known to have COVID-19. I wouldn't identify that person, and I would talk to them about the importance of self-isolating since the date of exposure. And I would seek understanding that the member of public understood what I was saying. We always knew the date of exposure, and the early data collection sheets that we designed included an algorithm which calculated the number of days and the end date for self-isolation that was required. And we did this in order to maintain consistency and reduce any risk of error. We would also provide healthcare advice and support and welfare advice, also about how to reduce the spread of COVID-19. And we would talk about getting in front of the virus. That was the sort of mantra that we used. We talked to members of the public about the importance of seeking healthcare promptly if they became unwell. And we encouraged people to contact the Ministry of Social Development for welfare support and the mental health support line, and of course, Healthline. After all this information was provided and felt understood, I would then ask for some demographic data. I frequently found myself saying, I know this is a lot of information. How about you get a cuppa, call your family, and someone will call you back to get some more details about where you've been. And when that call happens, why don't you grab your diary or your phone if you've got a calendar and have that handy? So that the message I'm wanting to give you now is that every time we had a call 3, it left with the confirmation to the member of public that someone else was going to call soon. And often they would be seeking clarity after that call. All 3 scripts were developed using a nursing care approach, that being culturally sensitive, providing reassurance about health and welfare, and directions about where to get help if it was required. My role was constantly evolving from making calls to teaching nurses and other healthcare professionals about making calls, managing complex calls, consulting with airlines, police, customs, intelligence services, both within New Zealand and beyond. I also was heavily involved in supporting those making the calls, providing pastoral care. In fact, it was very, very stressful for clinicians calling people. And of course, another very important role was revising the scripts and protocols for the COVID-19 outbreak as it continued to evolve and the messages changed and the needs of the public changed. As I said, we started making calls on the 19th of March with 5 nurses, and within 6 days we'd gone to a capacity of 150 callers, which included both nurses and other healthcare providers. So it was a phenomenal amount of education that we also did. Following this, I was asked to move into the planning and capacity leadership team. And my roles within that team included providing clinical advice, working collaboratively with public health doctors, and writing policy to ensure that the National Close Contact Service was underpinned by our foundational document, Treaty of Waitangi. A quality insurance program was embedded within it. The data was safe, protected, and cleaned, and along with all policies and procedures for the service. We ended with a capacity plan that was written which enabled the service to contact up to 10,000 members of the public in any given day, should that be required. And I'm confident that the National Close Contact Service that's currently in place is able to protect us in Aotearoa, New Zealand. What worked? Well, I think one of the things that really worked was that nurses were there at the beginning. Nurses are people who are able to establish a therapeutic relationship with somebody very quickly. And relationships is what makes nursing practice really good or not so good. And nurses are experts in collaboration. These skills allowed us to work in a multidisciplinary team and find solutions promptly. And to my mind, it's one reason why we were able to stand up the service so quickly. The other thing that I think was important is that nurses are trained to perform well in a crisis, sometimes leading them and other times following, being part of a team. In fact, sometimes a nurse in a healthcare situation is invisible, but never ever absent. In this outbreak, nurses were very visible, everywhere helping the public, and the public were relying on nursing. As a neonatal intensive care nurse, I likened the feelings of those first few weeks to feeling like we were in a continuous resuscitation in a constantly changing environment. And this meant to us that self-care was very important, both for us, as I've said, but also for our colleagues and the other members that were helping us. Our leadership was calm, clear, consistent, and while not always feeling like this, what we wanted to give to everybody was for everybody to know, in our team, to know and feel that we were capable and we've got this. What things might have made it easier for us? Well, for me, the biggest problem in those early days was the way that we received data. So the police were helping us and they were doing an amazing job, a really marvellous job. But those early days, we didn't have access to healthcare data. And so it was difficult to be able to track people easily and quickly. It's not the same now. I remember an example of this is I remember one call when I was calling a man, for example, his name might have been David, and I asked to speak to David, and the man that answered the phone was Jack. And Jack said to me, actually, I've got a brother called David. And he's given me his cell phone. And so it was about those kinds of things that made the situation a little bit slower. Now we have the National Close Contact Solution, which is a purpose-built data management system which enables us to access current data promptly. So thank you very much for listening to my early experience of being seconded to the Ministry of Health. I felt very honoured to be able to serve the country in this way. And I would like to leave you just with one point. The COVID-19 virus has one goal, and that's to infect the host, that's us. And while we have many goals, the important one in eliminating this virus is leadership, and that's been evidence-based internationally. If we continue to work as a team, we will be able to continue to lead the world in our management of this most significant global threat. Thank you.
Thank you, Fiona. Thank you, Deborah. That's a great presentation. And we're now going to have Dr. Fiona Imlach speak with us. Fiona is a Senior Research Fellow at the Health Services Research Centre. She's previously worked at the Health Inequalities Research Centre at Otago University and as a researcher at Plunkett and a principal researcher at the Health Promotion Agency. Her research interests are in the social determinants of health and health equity. Her previous research has explored the impact of poverty and other socioeconomic factors on health using longitudinal data analysis and looking at the effects of alcohol and alcohol policy on public health. Her current research project is enhancing primary healthcare services to improve health in Aotearoa, New Zealand. Today, she's going to be speaking to us on consumer experiences of primary healthcare during level 3 and 4 lockdown. And in particular, she'll cover off access to primary healthcare services during lockdown and mental health effects. Fiona, welcome, and we look forward to your presentation. And Fiona does have slides.
Kia ora koutou. I'll just share my screen. Okay, thanks for the opportunity to talk about this. This is some early results from research we did during lockdown. And just to give you a bit of background about why we did this, we were doing some work on patient experiences in primary healthcare in the healthcare home model of primary care. And we were just about to launch that really when we had to go into lockdown and we had to put our research on hold because we were planning on talking to patients face to face. And of course that was not possible anymore. So we wondered what we could do instead. And it seemed like there was a great opportunity here to look at how the delivery of primary healthcare had been changed during lockdown. So lockdown, we mean level 3 and level 4. And during that time, primary care was actually instructed to use virtual non-contact consultations wherever possible. And by that, it meant telephone, video, email, and that had to be done before any patient could be seen in person. That was the expectation. And of course that was done because we didn't want patients to be exposed to the infection. And also really importantly, we didn't want our healthcare workers to be exposed to the infection because there was a danger if we had system overwhelmed and doctors and nurses were sick, then the whole system would collapse. So there was a real forced change to delivery of primary healthcare from primarily in-person consultations to these telehealth methods, these remote methods of care. And what we've realised at the time of lockdown is that there wouldn't be any current data collection during the lockdown about patient experiences of healthcare. So normally the Health and Quality Safety Commission has a patient experience survey that collects data from primary care, but this just by bad timing was not in the field and it wouldn't be able to be put in the field during the lockdown period. They subsequently put in a survey, but it was sort of retrospective and only covered level 3. The other survey that we could have got data from was the Health Survey, New Zealand Health Survey, but that's a face-to-face survey, so that also had to be put on hold. They subsequently replaced that with a telephone survey, but they only had a couple of questions about access to primary care and nothing really about people's experiences. So we thought that we would take the opportunity to actually try to capture some of these experiences that people were having from this change in delivery of primary healthcare during the lockdown period. Just to give some context about primary care services before COVID, most consultations in primary care would be in person. There was some phone triage and some consults by phone happening, but this was not widespread. A patient portal is one of the ways that we can deliver telehealth. So this is an online platform that patients can use to access their notes, that they can view test results, they can ask for prescriptions, book appointments. Unfortunately, not all portals offer all of those services. And at the end of 2019, 2/3 of practices were offering a portal, but only around 20% of these patients at their practices were registered to the portal. Very few were using video conferencing, and the other options of how you access your results and things were a variable level of access to patients. So what did we do? We were thinking about how we'd actually get hold of patients. So we thought an online survey is probably the most feasible given the stay-at-home lockdown situation. We were wanting to get adults who needed to use primary care during the lockdown. We tried like a new way of recruitment. We used a snowball recruitment through social media and networks, our professional and personal networks. So this led to some limitations, which I'll come to soon. We were aiming for around 1,000 responses, and we got that. And the second part was actually using the survey to recruit some people for in-depth interviews so we could delve in a bit more detail about people's experiences. We were actually quite almost overwhelmed really with the number of people who volunteered to be interviewed. So over 400 people put their names down for us to interview. Of course, we couldn't interview 400 people, so we ended up doing 38 in-depth interviews. So the results that I have later on come from both the survey and those interview responses. Just to give you a picture of the timeline, so level 3 and 4 is the period of our interest. We had the online survey in the field during that second level 3 and part of level 4. And we had in-depth interviews that started a bit later. So some of them ended up being retrospectively asking people about their lockdown experience, but most of them were actually done during that lockdown. This is just to give an indication of our sample, and to note that the sample is not representative of the general population of people who attend primary care. So we had more women than men, and actually more women than men do attend primary care, but this is a bit more than usual. The age range was fairly good spread, but we didn't get the Pacific particularly, and we had an underrepresentation of Māori, and we realised that that would be difficult to recruit Pacific through the online methodology, and so that's the weakness of the study. We also had, this is again from our snowballing recruitment, a highest response from people who lived in the Capital and Coast and Southern DHB regions, and that's because a lot of our networks are based in Wellington, and also the University of Otago did a lot of help with our recruitment, so that was where a lot of our respondents came from. So there's some results here. I mean, the key message, which is probably not surprising, but most telehealth and most contact with primary care during the lockdown period was by phone. Very few video consults, only 5% said that they had a video consult. Interestingly though, 30% said that they'd made contact with their practice through a portal or website. So that suggested to us, that was more than we would have expected from the pre-COVID telehealth portal sort of statistics. So it suggests that more people were registering with the portal and more practices were promoting this. And even though practices were told they had to have telehealth as the first point of contact with patients, nearly over a quarter of people actually went and visited their primary care practitioner. So people were actually being seen when they needed to be. The key message that we have in terms of how people experience telehealth was that the satisfaction was high. 86% satisfied or very satisfied with telephone, 90% with the video consults. That's at least as good as what you'd expect from pre-COVID levels of satisfaction. One thing we did though is ask some people a bit more detail about the quality of the experience. So one of the questions we asked was, did you feel like the doctor or nurse spent enough time with you? And overall, again, over 90% of people thought that yes, with the telephone or the video, the doctor spent enough time, but there was a proportion, 20% of people with the telephone consults thought it wasn't it wasn't quite as good as in person. So even though the telehealth was working really well for most people, some people still thought it would have been better to be in person. What do people like about telehealth? Not really surprising, but one of the key things, and this has been found in previous research done before the lockdown period or before pandemics, it's really convenient. It saves people time, they don't have to travel, it saves people money. And the key thing, especially in this context, was that people weren't having to sit in waiting rooms being exposed to infection. And although that might be a specific COVID-related aspect, people did mention about the fact, even in regular times, they don't want to be sitting in a waiting room. They don't want to be sneezed and coughed on with even a regular flu. So that was a definite plus. There was certainly, people talked about the types of consult it worked well for. So regular routine issues, for prescription, things like issues that they knew well and their doctor knew well, very, very happy with having a telephone consult. And you can see from the 25% or 26% of people who went on to have an in-person consult, there were some things that didn't work so well for. But people valued being able to talk to their doctor, be reassured, having their issues sorted out and being listened to. And most people found it quite unhurried and timely. And actually a lot of people mentioned how they found it easier to get hold of their doctor during this time. The doctors often weren't so busy and so they could be seen quicker, and it felt like they were taking more time. I have to say, even though I've got what people don't like about telehealth, there were many more positive actually responses than negative. But the main thing that people talked about that telehealth didn't work so well for is when they needed to be examined, which is not surprising. So if they had an issue where they felt that they needed an examination, that meant they were less confident in the diagnosis, they were less reassured. Another issue that came out, but maybe not as much as you might expect, but still came out, was the cost of the consult. So a lot of the telehealth consults were charged at the same price as an in-person consult. Some were priced maybe half as much. And people were quite sensitive to that. So if they had a consult by telephone, which felt as in-depth and at the same sort of length as they would have in person, people were quite happy to pay for that. But if they had a consult which felt quite short, of a couple of minutes, even if they got their issues sorted out, they sort of felt like that wasn't so much value for money and they weren't so happy to pay a full price. People did mention some technological difficulties, but they were also quite good at working around them. So a lot of people took photos of rashes or other things and sent it to their practice. If the video didn't work, they'd change to telephone. So there were some technological difficulties, but people were pretty accommodating at trying to work with these around. And there were a few people who thought that the telephone particularly felt rushed or less personal, but some context around that. Some people found that even just the general demeanour of the practice in this really early kind of disruptive time, some practices felt kind of panicky and they weren't as organised as others. And for the practices where the practitioners were very calm and reassuring, this sort of comment didn't come out. Just some general data. We asked a few questions just around the pandemic and health. So this is around the level of concern people had around the impact of the pandemic on their health. And it actually overall is pretty high. So almost half of people overall were either extremely, very or moderately concerned about the impact of the pandemic on their health. A little bit higher in older people, as you might expect. And then another question as we asked is, has the pandemic made it easier or more difficult to manage your health? Interestingly for this one was the younger people who reported that they thought it would be more difficult to manage their health. And then people with long-term health conditions or disabilities, people who are unemployed or struggling with living costs also thought that it would be more difficult to manage their health. And just finally, I wanted to make some comments about mental health care and impacts on wellbeing that we got from the data. We didn't design the survey in terms of asking about mental health, but it's something that people talked about spontaneously, and there was a lot of data around this. So these are preliminary findings. I'm just going to show you a few quotes to demonstrate some things that we thought came out quite strongly. The first is around how people, there were variable experiences about how people found mental health services, and the impact of lockdown on mental health and wellbeing was also quite variable. So this is just a few quotes from different people around how they found accessing mental health services. So for people who had an existing mental health condition, the first quote there is when it didn't work very well. So this lady couldn't get hold of her psychologist and her mental health declined. But the next person actually found the opposite. She continued to connect with her therapist through video, and that worked well for her, even though she was looking forward to getting back to normal. For other people, even though the secondary services might not have worked well for them, they managed to get mental health support through primary care. And then there was another sense that some people didn't actually know what they'd do if they needed help. They weren't sure where that they would go for mental health support. And so maybe there was a group missing out there. But for people who did manage to access like the helpline that Deborah mentioned, again, kind of variable experiences. So the first person found it difficult to get hold of someone to talk to, and that increased their distress. But then another person had a good experience of the mental health line. So this is somebody who didn't have previous mental health illness, but she was feeling distressed by the lockdown experience, and she found that the helpline was really good at supporting her for that. In general, the impact of lockdown on wellbeing was quite mixed, but a lot of people found it quite positive. We had someone who said COVID was a gift to us. It helped us connect, it helped us slow down, but there were also things that couldn't work so well. So this first quote gives an example. A lot of people said that they drank a bit more than usual, and this might not be the best way of coping. So even though the time pressure was less, they felt like the pace of life had slowed down. A lot of people said that they could do more exercise, but there were still stresses. So for this lady, the stresses was around finances, relationship with her husband wasn't so good, and so there was a bit of a mixed bag. The issue around connections and social connections and relationships, again, quite mixed. So the second person here was really valuing the quality time that they got to spend with their relatives. People who were living alone but isolated, that was the thing they struggled with, even if they had more time to go for walks and have a better diet. So again, a mixed bag, some things positive, some things negative. So just concluding, things that we found so far is that this sort of unexpected crisis disruption, really sudden change in delivery of primary health care, could actually be a positive thing. Patients were very satisfied with the services overall that they received and found it a positive experience in a lot of cases. And telehealth specifically was able to deliver care that was at least as good as in-person care for a lot of people in a lot of circumstances, but it was quite clear that it wouldn't work for everybody in all circumstances. In terms of mental distress, the lockdown exacerbated it for some people, and services didn't always respond or wasn't always available. And in general, experiences in lockdown actually could provide an opportunity for positive behaviour changes. I'm not sure how embedded these changes will be, or whether people will continue some of these positive changes, but it was certainly an opportunity. But then there were also some negative things that could creep in there. And my final slide is just acknowledging my team. Great thanks to the survey and interview participants that gave us all this really rich data. And this was a HRC funded project which we transformed into this research.
Thank you, Fiona. That's terrific. And we greatly enjoyed your presentation. And now we'll go to the questions. So let's take them in order according to the voting. So Deborah, for you first, what would you have done differently?
The things that we found difficult was something that Fiona talked about, was the lack of capacity. So, for example, referring people to Healthline and then taking sometimes up to 2 hours for somebody to answer the Healthline call. So having more support in those very early days for members of the public, I think that would have been brilliant. Excuse me. The other thing that we won't ever have to go through again is having a robust data collection system, which we didn't have. We designed our data collection sheets using Excel, you know, for those initial times, and the risk of making an error, you know, was high. And although we were aware of that and we worked very hard with that. So if we could start again, it would be to have a good data management system.
Thank you for that. So the next question is for you too, Deborah. Is the 3-call model still employed by the Ministry of Health? And are you aware of any updates that have occurred in the contact tracing protocol since the early setup?
So thank you for the question. It's a great question, and yes, the 3-call model is still used. However, there is additional calls now, welfare check calls, which are largely done by Healthline, because we found that we needed to contact people during the time that they were self-isolating or being in quarantine, as would be the correct terminology. Quarantine for quite well, self-isolation technically is for somebody who is ill. So there is an extra call in there, but it's not called call 4, it's called wellness checks. I think it's a model that works very well. In terms of have there been updates in national contact tracing? Yes, I'm sure that there have been. I haven't been actually in the Ministry of Health myself for the last couple of months. I've been back at the university, but it's a constantly evolving process with people reviewing what's working and what's not working all the time. So I can't update you personally, but I feel sure that people are working on making sure it's current.
Thank you. And now here's one for you, Fiona. Is there a potential to have a practice that is not local to the customer respond in telehealth? This would have a desirable impact of introducing competition. So I think the question might be going, so what say somebody from Whangarei wanted to answer a question in Invercargill, or even a contracted source overseas?
I mean, telehealth was almost designed for this kind of thing, really. For example, in Australia, telehealth's used to connect rural communities with specialists in other, actually even in New Zealand, there's been initiatives in Northland, for example, where you can get specialists to review a patient. So they don't actually have to be, don't have to travel, go there. So exactly, telehealth is definitely got the potential. I'm not sure about introducing competition. I think it's actually improving services so that people who are particularly in remote areas will be able to access specialists and other people to support their health needs without the burden of having to travel a lot and spend costs on that. The other thing in terms of COVID specifically, people did have some concerns about the fact that they were told to stay at home, but their primary care might be located where they work, which they could travel some distance to. So there was some confusions about whether it was allowed to travel out of your neighbourhood to your primary care. But telehealth can actually get around some of that because you can connect with your usual provider through video or telephone and then get the advice about what to do. So it certainly has great potential to reduce inequalities and improve access for people who might not otherwise be able to travel.
Okay, so the truth of the matter is we already have telehealth after hours. So if somebody wants help after hours, they call Healthline, and I can assure you that's not going to be based in Fielding. So, you know, people are already getting health advice. What do you think about the notion of the provider of the Healthline service not having access to the patient's clinical records?
Did you say not having access? Or,
yes.
I mean, it would be advantageous if all of our health services were linked up. So we must also make sure that we've got privacy and security set up, but we haven't quite cracked the whole medical linked record yet. So ideally we could improve our services if we could integrate secondary and primary care, that we could have a picture of the patient so we know what medications they've taken, what their conditions are. So this goes beyond telehealth. It's more like a digital, I guess, bringing together of all of our health services to actually enable us to deliver better care.
So Deborah, you must have had some experience in this space. It's often a thing that's raised. Can Healthlines and generically speaking, provide the best service?
I think Healthline do provide a service to the public that's outstanding. And I'm really pleased that we've got that service in New Zealand. if they are out of their depth and they can't provide this advice, then they know where to refer to. And so it does mean that, I mean, my experience with it largely is with mothers and fathers of brand new babies, and you know, that's often a time in somebody's life where they need an awful lot of support and advice, and they might just be slightly worried about something, and they're not sure whether they need to access, you know, increased services or take the baby into ED, and particularly when they might not want to do that because in the COVID kind of time. So that it does actually provide a fantastic service for what it's meant to do.
Thank you very much. Now, we'll go back to Fiona. There's a question here. Fiona, do you know if there has been an increase in the use of telehealth in post-lockdown times?
Well, it actually has kind of bounced back to normal. So a lot of people have just reverted back to the usual in-person care. So as far as the most recent data I've seen is that there has been an increase in telehealth compared to before COVID, but certainly nothing like the levels that we had during lockdown. In some ways it's a bit disappointing because a lot of people had a really good experience with telehealth during lockdown, and it was definitely, we got great feedback from people about how they wanted it to continue. They wanted to still be able to access their primary care through telehealth, but it's not clear whether this isn't happening so much because patients have stopped asking for it or because practices have just reverted back to what they know, and maybe the systems are not there to support them, particularly financially. It's been quite difficult for practices, I think, to figure out how they can charge appropriately for telehealth, and that's something that really needs to be sorted out.
Thank you. Now, here's another one for you, Fiona. In medical terms, and I hope that's a very broad term, including both medical practitioners and nursing staff. In medical terms, what was the quality of the medical consult? Have we learned something that can be applied to business as usual? And how much more cost effective, it says, % is this interaction? So it's a question around the quality and the cost effectiveness of the interaction.
I can't answer the cost effectiveness question because we didn't look at that, but I did show you one slide around the quality measure, and we asked quality in terms of, this is the patient experience, so we asked the patient to rate the quality on 4 measures, and I showed you one thing, but I'll just show you the 4 questions that we asked. I'll share the screen. So you can see that we asked 4 questions. The one I showed you is around spending time. We also asked people, did the doctor or nurse explain things to you in a way that you could understand? Did they treat you with kindness, and did they listen to you? So for all of these things, overall, telehealth rated highly, again, more than 90%, but you can see there was a small percentage of people on the other questions there that thought it would be better in person, so that's the little red percentage. I think in terms of quality, in terms of what we could apply to business as usual, we know that telehealth doesn't work for all situations and for all people, and I think this is demonstrating that. Obviously, normally you would offer telehealth as an option, whereas in this case, in lockdown, everybody had to do it. So there's some situations where telehealth doesn't work. It's not appropriate. If somebody has to be seen, have to be examined, and I think that's what we're picking up here. There's some things where it doesn't work, but if we go back to business as usual and you give patients the choice about the type of service that they want, I think that that level of satisfaction on these quality indicators will be high.
Thank you. Now, I've got a question for Deborah. Deborah, how ready do you think we are to cope if there is a sudden influx of community transmission?
Thank you. Thank you, Gregor. I think we are ready. I really don't want that to happen. Nobody does. And I think having our borders closed, and if only those people would stay in their in the border quarantine places and not come out, that would be super. But I think we are prepared and ready to go. In fact, I'm confident that if we do have an outbreak, that the service that is created will respond appropriately and continue to protect us. I know that, and I have heard in the media quite a lot of concern about the lack of use of the app and the New Zealand public not completely engaging in that. And I've thought about that quite a bit, but my reflection on it is this. Actually, we didn't even have the app to begin with, and we did that contact tracing and we were able to get to elimination. And not only that, we've kept it there for over 90 days now. And so I think as long as we continue to work as a team together, all of us in New Zealand, I feel assured that we will be able to do effective contact tracing again if we have to.
Okay, thanks, Deborah. Now, look, I've got a tricky question for you. How long do you think New Zealand's borders are going to be closed for?
How long is a piece of string? I'm not sure about that. I do remember the weekend before the borders are closed, I was working in the Ministry of Health at the time, and I was walking around Eastbourne, and I knew what was happening and was very cognizant of the data and thinking about it. And I turned to my husband and I said, if I was Jacinda Ardern, I'd close the borders. It's going to be the only way to control it. And it happened a few days later. I think opening the borders is going to pose a risk for us. And so I'm not sure quite when we're going to do that.
Thank you. Well, my next question, since there aren't any sitting at the moment, is actually for Fiona. Fiona, what do you think was or is the accumulated healthcare deficit that happened during the time of shutdown? So the question is, do you think there is a whole lot of unmet health need that has accumulated that hasn't been dealt with?
Oh, I can show you something. Oh, sorry. Yes, I mean, there definitely will be. I'll show you another slide. Hang on. So we did ask people about whether they delayed seeking healthcare. About half of people said that they had, and you can see on this slide here the reasons that people gave for delaying seeking healthcare. And the big one actually was concern that the healthcare workers were too busy, that their problem wasn't urgent enough, and so resources were needed for more urgent problems. So people were really triaging themselves. They were saying, I don't think this is a serious concern, I don't want to bother anybody. Also, there was the next group, 20% of people said that the service that they had already booked or planned or was supposed to happen, that was delayed or postponed. So that will have consequences for people. And then people were not seeking healthcare because they were afraid of being affected. There was a lot of fear out there, or they just couldn't get hold of the healthcare. So I think from these responses, the people that delayed seeking healthcare, there will be consequences for that. But from what I've heard, services are catching up. And primary care hasn't been overwhelmed with people coming in. And we certainly had stories from our participants that they triaged themselves. They thought they had a concern that they would normally see their doctor for, but they just decided to manage it themselves, and they managed fine. So there was definitely some people who didn't go and seek care, and it all worked out fine. But I'm sure that there will be people who decided not to go, but there will be subsequent consequences for that.
Thank you. Now, that was a really interesting study that you conducted. I'm interested to know, did you look at the other side of the equation, if you like? So you did a survey of patients. Did you talk to the practice staff, nurses, doctors, to get their view of the success of telehealth in COVID-19?
No, and the reason we didn't do that is that we knew that other people were doing that. And so we were afraid that the patient voice was going to be lost because there was no ongoing, at the time, data collection around patient experiences. So we have already getting some results looking at the practice perspective, but we really just wanted to focus on the patients. But it will be interesting to sort of marry those results up and look at why there are differences. So one difference that has come out is that from our survey, our patients were quite astute in terms of knowing what things needed to be seen in person and what things that could be done by telehealth. The feedback I've seen from practices is that they don't think that patients are very good at that. So it would be really interesting to understand that a bit more about why there's that difference.
All right, thank you very much. We're going to close the seminar now. So thank you for joining the first of this Spotlight series on COVID-19 and public health. Tomorrow, we've got our second in the series at the same time, 12 midday. We'll have Prof. Colin Simpson talking about what does epidemiology research tell us about COVID-19. And then we'll have Dr. Anna Matheson talking to us about COVID-19 and equity. And she'll be followed by Dr. Tara Officer talking about pharmacy practice under COVID-19. Thank you again, all of you, for attending, and we look forward to seeing you at tomorrow's webinar. Thank you. Cheers.